Uh, Good evening, friends from India. And once again, it's been 29 months with all of you, month after month. And now we join after the summer break for the last two webinars, which are the most important for all the practitioners, that is, the surgical interventions in uveitis. Now, before I give the thing to John and Rima for today's proceeding, two important announcements. First is we are going to have an advanced course in uveitis in the memory of our President Manfred Zerhut, and it will be done at PGI Chandigarh between 25th to 28th January, and you will all receive the details to register within 1 week. Limited slots available, and we look forward to your participation. The second one is that we will be now coming up January onwards with grand rounds in uveitis by IUSG. So whatever topics have been covered in the past 30 months, we are going to go topic-wise. Each topic will have a basic, intermediate, advanced course. Discussion would be there, and all these grand rounds will be compiled by Alejandra Di Torre from Colombia in the form of a book, which will be available to you guys for ready reference anytime in future as IUSG Grand Round. With this, I would thank all the speakers from different parts of the world, difficult timings for many of them, for joining us, and pass on to Rima and John, who are part of our education committee of IUSG, to conduct today's webinar. Please type your question answers, and we will take up controversies towards the end. Yes, John, go on, please.
Is John on?
I think John's internet was unstable. Rima, you can carry on.
Okay, so thank you, ma'am, and welcome to you all. So with this, we now start the first talk of this course on this webinar on cataract surgery and uveitis. And for this, we have Lucia Kifova, who will be talking on complicated cataract and uveitis and its pathogenesis. And Lucia is from the University of Aberdeen. She's a clinical senior lecturer and consultant ophthalmologist surgeon. Over to you, Lucia.
Good morning. Thank you very much for the kind invitation and opportunity to speak about complicated cataracts in uveitis, particularly pathogenesis of uveitis itself. I am at the moment in Bermuda, and assuming that the weather condition will not change, we will have our internet and hopefully finish the talk. I have no financial disclosures in regards to this topic. So before I would start to speak about the pathology and the cataract itself, I wanted to start with the lens and remind to ourselves that it is a very specific organ in the eye which does not have a blood supply. It is without innervation, and any nutrition which is delivered into the lens for the normal functioning is delivered by the aqueous humor. The same way the waste is being removed from the as outcome of the metabolism of the lens itself. The main function of the lens is the refraction of the light, and that is in regards of the refraction error and the changes between the aqueous humor and the vitreous itself. But the lens is the organ in the anterior segment of the eye, and it's growing during the lifetime, reaching adult size about 9 millimeters in super anterior parts, and the depth of the lens is about 5 millimeters. The lens contains a lens capsule, which is basically a basement membrane containing collagen 4, and it's the thickest in the equatorial parts. The main function of the lens capsule is to, while accommodating the lens, make the shape of the lens, which can change from the form of the lenticle to the form of the flattened lenticle, which allow us to see in the long distance. So the default of the lens position is for near. Now that is allowing us to accommodate, and there's a huge decrease over the lifetime of the every person, while we are able to accommodate about 16 diopters when we are teenagers, which is reducing progressively and reaching about 2 diopters only when we are reaching the 50s. The lens is attached to the cellular body with fibers, which we call zonules, and these are inserted into continuous fashion on the equatorial parts. The main and very important part of the lens is the lens epithelium, which is a single layer, and it's metabolically very active, particularly in the equatorial parts of the lens itself. The role of the lens epithelium is production of the lens fibers. These then do lose the nuclei and forming nucleus in the cortex. So as we are aging and the lens is producing more and more fibers, we are having a thicker and thicker lens. Interestingly, there is no difference between the cortex and the nucleus on the microscopic levels. And the structures which we do as a surgeon describe as a nucleus, cortex, and epinucleus are histologically exactly the same. Throughout the life of the individuals, there is no cell loss, and therefore the oldest fibers are forming the nucleus, and the newer fibers are forming the outside of the nucleus parts and the cortex. So on this picture, you can see where in the equatorial parts, lens epithelial cells are producing new cells and the new lens fibers. As they are going inside of the matter of the lens, they lose the organelles until eventually they lose the nuclei. And in the area of the mature fibers, these are forming one large syncytium and anucleated cell aggregation. Now, the main reason why the lens structure is allowing us to focus as well as allowing us to actually see is the water balance. And there's a very tight water control inside of the lens itself, maintaining about 2/3 of the water and 1/3 of the protein. Now, there is a different water content in the different parts of the lens, which allows effective light transmission. And the cortical part of the lens itself, it's having a little bit higher content of the water than the nuclear part. Now, when there is too much of the water, then the cataract starts to develop. So the main structure or main protein of the lens is crystallins. These are the proteins which are water soluble. We do produce them much more readily when we are younger, and there are 3 different types of the crystallins, alpha, beta, and gamma. And we know that by any genetic mutations in either of the structures of these proteins, there is a development of the cataract or inherited cataract developing in these unlucky individuals. Now, the lens of proteins, and particularly the 3D structures, it's allowing us to see and allow to transfer of the light from the front into the retina in an unscattered fashion. As we are aging, the oxidative stress as well as a byproduct of the metabolism are changing the structure of the crystallins, and these later on are less effective to block out the own refraction of the light from the protein themselves, and that light scattering is causing a functional decrease of the visual acuity later on in the life. There are other type of the proteins that are contained in the inside of the lens, and which are water insoluble, but they are still urea soluble. And these are usually the cytoskeleton proteins, which we at the moment do not know fully the function of these protein, apart of the fact that they are allowing crystallines to be cross-linked in a fashion that they will effectively transmit the light. There are also the third type of the protein inside of the lens matter, which are urea as well as water insoluble. And these are water channels, aquaporin, which are extremely important for the water content regulation inside of the lens itself. So you can see that aquaporins are allowing for water transfer from aqueous humor into the lens, as well as from the lens to the aqueous humor. Lens itself, as well as the corneal epithelium and endothelium, is allowing two-dimensional transfer of the water, while the other structures, particularly retina, choroid, it's allowing only one-way transfer of the water outside from the tissues. Now, this tide regulation is extremely important for the remaining and retaining the clarity of the lens. However, that requires energy, and that is being delivered by passive or simple diffusion, or by active and facilitated transfer of the glucose from the aqueous humor. Once the glucose being phosphorylated, it's entering in about 90% into aerobic glycolysis inside of the lens epithelial cells. But about 5% also goes to pentose phosphate pathway, and these are responsible for generation of the new crystallines. And there is also about a fraction, about 5% of the glucose enter the sorbitol pathway, which is much higher in the diabetic patients. And that is the reason why diabetic patients do have abnormal content of the protein, which allows the more ready binding of the water, and therefore early onset of the cataracts in these patients, as we know clinically. Now, normally, why the lens is developing cataract is because the crystalline structures and the crystallines themselves are damaged by oxidative damage. These are normally generated by the normal metabolism, but also if for whatever reason there is either too high or too low oxygen amount inside of the tissue, this is directly causing abnormal cross-linking and polymerization and DNA damage, and therefore onset of the cataract. So the balance of the oxygen as well as the balance of the water is extremely important, and preventing cataract development if this is in proper shape. Now, the crystalline misfolding itself allows for the light scattering and precipitation, and that is then causing secondary cataract. So the cataract is a major global burden. In 2020, we have about 94 million people of the significantly visual impaired. And the main reason of the visual impairment is cataract, which is still in the first place of the global blindness. When we look at the prevalence of the cataract blindness in the developed countries, about 1 to 2%, but is much higher in the developing countries, as you can see in the red. The simple cataract operation has been shown to be the main reason for improvement of the quality of life of the individual, and therefore the advocation is out there to offer this as much as possible to improve the quality of the life of the people. There are 3 different types of the cataracts. Typically, nuclear and cortical cataracts are age-related. We all over the age of 50 do have some level of the nuclear sclerosis, which is impinging on our ability to see in the long distance, but also allowing the eye to become more myopic as the nucleus is maturing. This will cause the reduction of the color recognition particularly, and it's the blue wavelength of the light which is the most affected initially. The cortical cataract is usually a sequelae of the misregulation of the amount of water coming and staying in the lens itself. It is less predictable and usually leads to complete cortex opacification and further liquefaction inside of the lens capsule and causing Morganian cataract. More typical and what we see in the uveitis patients is development of posterior subcapsular cataract that is usually affecting the posterior cortex and usually affecting the axial position, and therefore the patients are much more symptomatic with the glare, poor vision, and monocular diplopia. This type of the cataracts is also associated with the medication-induced cataracts, particularly systemic or topical steroids, but also phendiazine and miotics. What is very interesting that this type of the cataract can reverse and can also progress very fast if the medication is unchanged and offered to the patient for a prolonged time. So the uveitis cataract is unfortunately a combination of the development of the intraocular inflammation itself, but also as a sequelae of the treatment which we are offering for uveitis, and prolonged steroid use, whether it is in the topical or systemic form, is leading a very early onset of the cataract. Typically, it's a combination of both, and also on top of it, adding the factor of the aging of the lens. These could be simply focal, lamellar, or anterior cataracts, which are not having much impact of the vision, as you can see in this case of the herpetic uveitis. But it could be also quite dense, involving the posterior cortex, or combined of the corticonuclear cataract, as you can see in this patient with panuveitis. Cataract is responsible for about 40% of the vision loss in the patient with uveitis. However, if you look at the amount of the cataract operation amongst all conditions, uveitis cataract is only about 1 to 2% of all cataracts which we as ophthalmologists are performing. And therefore, they are relatively rare, and there might not be enough experience amongst the general cataract surgeons, which I'm sure we will discuss this in the controversies. Now, as we know, there is a huge difference between the incidence of the cataract in the different uveitic conditions. And although every uveitis and the treatment which we offer for uveitis does cause the cataract, there are conditions which are more likely to develop cataract, like Fuchs heterochromia, or a pars planitis, where the patients are almost in 60 to 80% developing the cataract during their lifetime. So to conclude, cataract and the uveitis is a sequelae of the uveitis itself, as well as a treatment for uveitis. It is very likely that it's more surgically demanding, because not only we will be dealing with the cataract, but also with the structural abnormalities in the anterior segment, including posterior and anterior synechiae, and different density of the lens cataract, which we do see clinically during the operation. Also, it's likely less predictable outcomes post-operation. And what is very important, as we will hear from other talks, I'm sure, the timing of the surgery and also the management of the expectation of the patient and consenting is extremely important. With this, I'll leave you, and we'll take the question. Thank you.
Thank you, Lucia. From this elaborate pathogenesis on cataract in uveitis, so we now move on to our next speaker. We have Heloisa Nascimento. Heloisa is head of uveitis services in Paulista School of Medicine and has been the president of Brazilian Uveitis Society. And she'll be talking on pre- and post-operative considerations for cataract surgery in uveitis.
Thank you. It is an honor and a privilege to be with you all. And I'm going to share some of my experience with cataract surgery in uveitis. I have no financial disclosure. So cataract is the main complication of uveitis, and I usually tell to my fellows that is the natural course of uveitis. Sometime we will have to handle this. Almost 35% of all uveitis complicate with cataract due to both the ocular inflammation itself and also to the steroids use. So when we have a patient with cataract, first we need to think about the indication of the surgical procedure. For example, this is a sarcoidosis patient with deep corneal opacity, posterior synechiae, and a +1 subcapsular cataract. Her best corrected visual acuity is 20/25. It is possible to examine the fundus. So will we indicate the cataract for her? No, we don't need to indicate the cataract for her because it does not prevent the fundus evaluation and the patient regular activities. It is different from this other case that she has total cataract, so the vision is only light perception. So in this case, the patient needs the cataract surgery because she doesn't see and we cannot examine the fundus, which is really important for us to follow up her uveitis. So in the preoperative evaluation, we need to check the visual acuity, the fundus examination. We should not operate if it's not necessary, and a proper uveitis diagnosis and treatment must be made before the surgery. And why are we afraid? Because we have many additional complications in patients with uveitis. So we have a lens capture in many uveitis cases, especially JIA. We can have ephema and a very complicated inflammation. We have dramatic cases in the postoperative phase. And that's why we need to be really careful in this indication. This review shows that despite the challenging surgeries and additional procedures that can worsen the final outcome, such as anti-glaucomatous surgeries and retinal surgeries in a younger population, the cataract surgery improves the vision in 90% of the cases, and it's safe and effective. This other study shows that almost 70% got better than 20/40. We should use acrylic IOL because this patient might need vitrectomy with silicone oil in the future, or a corneal transplantation. So we should not use silicone IOLs. The surgery in the acute phase is related to worse prognosis. So that's why we need to control the patient for 3 months, if possible. Fuchs has a better prognosis, and Behçet's, VKH, and sympathetic ophthalmia have a worse prognosis. So the key to handle cataract and uveitis is to individualize patients, to have a proper diagnosis, and an absence of inflammation for 3 months. But there are exceptions to this rule. For example, if we have kids younger than 7 years old with bilateral cataract, that if we do not operate, we should raise an amblyopia in the kid. Or if we cannot completely control the inflammation and we cannot see the fundus and the uveitis activity in any other patient. It is very important, and although it is basic, sometimes I have cataract surgeries calling me, asking me which lenses should they implant, and the first question I always ask is, have you done the proper diagnosis? Does this patient have syphilis? And sometimes it is basic for us, but it's not basic for the cataract surgeons around the world. So we need to rule out infectious disease and treat before the cataract procedure. So this is a 29-year-old patient with JIA. that has done a surgical procedure 15 years ago with IOL implantation. And look how she complicated her IOL opacificated. She had a pupillary membrane, and this patient evoluted to no-light perception. So we should be really careful in indicating IOL for JIA. I particularly prefer to leave the patient aphakic. So the factors that are related to a better outcome are aphakia, and post-therapy did not change the outcomes. So if we have a patient, a young patient, children with JIA, you should not implant IOL. So I'm going to show you this case of a 4-year-old boy that he came bilaterally with dense cataract, and I tried to introduce steroids and methotrexate and Humira, but he was blind in 2 months. So I had to operate him before the time of 3 months because he was not seeing anything. And this is an exception to the rule. So after the surgery, this is how he looks like, aphakic. And now he's 6 years old. It has already 2 years. And he achieved, after occlusive treatment in one eye, he achieved 20/25 in both eyes with plus 16 of refraction. And I was very happy to see this patient return to see. So a happy patient and a happy doctor. So an absolute contraindication for IOL is JIA, although there are several ongoing studies about it. But every time that I tried to do it, I regretted myself. A relative contraindication is the pattern of the posterior synechia. Sometimes we have a tuberculosis or a syphilis or a VKH that is so aggressive that we have to think twice on indicating the IOL. So the key is to individualize the patient. So this is a sarcoidosis patient. You can see that he had a previous iridotomy, and sometimes I use this iridotomy to inject the trypan blue so that I can try to dye the anterior capsule before making stretches in the pupil, so it can ease my surgery. This is another case that I did the same. So the cataract surgery in uveitis is challenging because the posterior synechia prevents the patient from pupil dilation. So we should be really careful and remove the membranes, sometimes stretch the iris, and you can see that the synechia is all around the surface of the iris. The cataracts are usually soft because the patients are young, and many times it's a posterior subcapsular cataract. So sometimes we need to use iris expansion devices, but I confess that if I have a 5 millimeters dilation, for me it is enough. And I think that when I use the devices, the patient has more inflammation in the postoperative. So I think twice in indicating. Obviously, there are cases that are so hard and so extreme that we really need those expansion devices. We can have lens subluxation in normal VKH cases, and Fuchs heterochromic iridocyclitis is a triad of uveitis, heterochromia, and cataract. And glaucoma is not on the triad, but may be present in some cases, about 20%. Especially in Fuchs, the cataract, it's not complicated, but we can see the Amsler sign, which is the development of ephema when we have the anterior chamber discompression, as we can see again in this case. This patient did very well. She was hand movements, and now she is 20/20 and she has no glaucoma. Ankylosing spondylitis is another challenging disease because we need to remove the synechias before doing the cataract surgery, but usually a condition that goes well with intraocular implantation. So from all our challenges, we have many postoperative challenges that are amblyopia, aphakia, control of inflammation, posterior capsule opacification, and a chronic cystoid macular edema. There are many approaches for the postoperative period. Usually, as we did the pre-operative protocol in a proper way, this patient is already controlled and he needs to keep the preoperative medication so he can have a better outcome. But sometimes when the patient has cystoid macular edema, we can use intravitreal dexamethasone implant or periocular or intraocular triamcinolone together with the surgery. And I am sure that in the future, not so long from now, we will have new polymerase of steroids that will help us to handle the cataract surgeries and uveitic condition. So in summary, if we have a diagnosis of cataract, does it interfere with the vision or uveitis follow-up by the fundus exam? If it does not, we should not operate. If it does, we have to control the inflammation, if possible for 3 months, evaluate the pupillary dilation. If it dilates well, we go to surgery. If not, we plan to use expansion pupil devices and go to surgery. And in the surgery, we have to be cautious on JIA patients, and the postoperative inflammation control plan must include, if necessary, intravitreal or periocular steroids. And now I want to show you all a case that that was really interesting for me. This patient came from the north of Brazil, and she had no light perception in one eye, and this eye was her only eye. And she had a band keratopathy, anterior synechia, and I wasn't able to see her pupil. So this is the other eye that she was no light perception. We decided to do PTK to remove her band keratopathy. And then we thought here that she had a cataract with posterior synechia. So after controlling the inflammation, we entered in the surgery. And in the moment that we removed this pupillary membrane, we were able to see by the red reflex that her lens was unexpectedly clear. So we just removed this membrane, and we did not remove the lens when we did the surgery. And we have repeated it in some other cases in children. And this is how she looked in the postoperative with her lens. And we can see it was not opacified. She had not cataract. And for my surprise, she was 20/40. And when I asked her to read the distance visual acuity, she told me that although she was able to read, she didn't know how to read because she only knew Braille. And so she learned how to write and the letters after the age of 11. And now she's a woman, and I'm so proud to have seen her and to treated her in a good manner. So thank you so much. It was for me a privilege to be here with you.
So thank you, Eloisa. That was wonderful, knowing the nuances of the surgery and excellent results. Thank you. So with this, we now move on to the next speaker, Dr. Soon Fek Chi. She needs no introduction. Dr. Soon Fek Chi is a distinguished professor of clinical education and ophthalmology at the Duke National University of Singapore Medical School. She has been the president of Asia Pacific Intraocular Inflammation Study Group, also a senior consultant of Ocular Inflammation and Immunology Department and the Cataract and Comprehensive Ophthalmology Department at Singapore National Eye Center. Dr. Chi will be presenting her talk on the surgical management of complicated cataract, the tips and the tricks.
Thank you so much for inviting me, and let me share my slides. I hope my screen is clear.
Yes, Soon Fek, you need to go
Okay.
yeah, perfect.
Thank you. So I'll be sharing on some surgical management of complicated cataracts, tips and tricks. My financial disclosures, no relevance to the talk today. So very often we have cataracts in uveitic eyes that have got synechiae, and hopefully they are mild, not like what we've been seeing shared. So if this is mild, you can see after injecting viscoelastic into the anterior chamber, I would then release the synechiae using a cannula or a Coughlin hook. And then if it is not scarred, I would stretch it. But very often today, I prefer not to stretch, and I prefer to use pupil expansion devices if it is not adequately dilated. Now let's have a look at this other case here. You can see a pupillary membrane with synechiae, and I'm just using a cannula even without viscoelastic, and a Coughlin hook, which is very useful push and pull instrument. And it's very important to remove this membrane, and you saw that after that, it was really quite widely dilated. Now this is a occluded pupil, so where to start? We just pick off the membrane by lifting the iris, and that will actually, being adherent to the membrane, show you the plane to start lifting this membrane that's occluded the pupil off the anterior capsule without causing any damage. So it's important again to remove this completely to allow even expansion of the pupil. And sometimes you may see a little bit of bleeding there, but it's usually limited. And the tags, I would then cut them off. And in this case, I expanded it with iris hooks. Now, look at this patient now has got peripheral anterior synechiae. So I'm going to release this. Now, be careful when you release it that you do not detach Descemet's membrane. The next step is to remove the pupillary membrane. And I'm starting to stretch, but you see here it's beginning to tear. So when it begins to tear, it will cause more inflammation and breakdown of blood ocular barrier. So we do limited sphincterotomy. It's just 1 mm cuts and multiple cuts evenly. So pupil expansion devices are sometimes needed. As mentioned earlier, membranes must first be removed. And you must see that the iris is something that you can stretch, because sometimes if it's chronically scarred from chronic anterior uveitis, you may induce tears like what I showed earlier. Now for a small eye, as in the pediatric eye, shallow anterior chamber, a very small pupil, a stiff iris, this would be indication to use iris hooks rather than expansion device that has got a fixed diameter to which the device would expand the pupil to. So this is the device I would choose if it were a deep anterior chamber, the iris is not atrophic or scarred. You can use a Beeler pupil dilator, which is something which you can reuse and autoclave and reuse, so that will actually save cost for your patient. I prefer generally to use a Malugin ring, and there are 2 versions there with different dilation sizes. But really for the uveitic eyes, 6.25 mm is adequate, and 7.25 is meant more for IFIS patients. In India, you can have the BHEX ring, which is very nice and slim, but we don't have that available in most parts of the world. So these are some devices, as I mentioned here, that can be quite useful. And we shall have a look at how these are used. So this patient has chronic sarcoidosis. And first thing to do, if there's peripheral anterior synechiae, you can see me releasing that. Again, just with cannula, I'm not injecting viscoelastic, I'm merely nudging it. And then I lift off the membrane. Okay, so I always do peripheral anterior synechiae first, because the posterior synechiae holds the iris taut, and then I remove the membrane. Now be very careful. If you're pulling too much, the angle can start to bleed. I'm going to use iris hooks because this is a chronically scarred iris. It's not going to be able to stretch easily. So I'm going to put it iris hooks in a diamond fashion, all right, so that we retract the iris away from the incision here where the phaco probe is coming through, and the direction for your paracentesis is towards the pupil edge. So after inserting 4 iris hooks, you see that I'm not stretching it too much, and you watch over this area as I begin to stretch. Look, it's ripped. Okay, so you want to do this very carefully when you have an iris that's chronically scarred like this, and you can then slowly expand it more after you introduce further cuts. So this is really the concept of episiotomy, right? You make cuts rather than tear in an irregular and uncontrolled fashion. So after a little snips here, I then slowly do expansion of this pupil in a graded fashion, and I just watch in case it tears further. So this is the fellow eye of the same patient with sarcoidosis. Again, peripheral anterior synechiae, I'm just nudging it towards the periphery. If you sweep for such broad peripheral anterior synechiae, you will end up detaching Descemet's membrane. So be very careful. You can use a gonial lens there, but most of the time I find that this is really not crucial. And once you've released the peripheral anterior synechiae, you can then put the paracentesis there for the side port. And again, it's important to release all this membrane, and you see it's not coming. I'm going to end up really stretching and tearing the root of the iris if I persist. So I'm providing a counterforce to this with a second instrument that comes in from the side port. And as you can see here, using non-tooth forceps, I then grasp the membrane and I tear around 360 degrees to release this as completely as I can. This will then allow the pupil to expand more evenly and more completely. So once I've done this, I'm then going to insert a pupil expander. So inject some dispersive viscoelastic, and again, as I said, this does not dilate easily, so it's atrophied, so I use iris hooks. So you can see the results of the patient, right? This is the one that had a bimanual pupillary membrane removal, and this was the earlier one that you saw that has a more regular pupil, but they were both quiet after the surgery. So this is showing you the use of a Beeler pupil dilator. You can have 2 or 3 pronged hooks at the end of this device that you can reuse, and you can have the device that goes through even a 2.2 mm incision, or in this case, a 2.75 mm incision. So you need to balance the hooks on the edge of the pupil and actuate the device, and it helps by injecting a little viscoelastic under the iris, and be careful when you walk out of the incision, you do not catch the lip of the incision. And you have a very nice, well-rounded, dilated pupil for which you can proceed with surgery. Now let's have a look at this patient here. You can see again synechia, and just using the Coughlin hook to easily release the synechia. In this case, it's a little adherent behind the posterior leaf here. You can see the fibrosis. And I'm going to use a Malugin ring. This is the first version, which is made of proline 4O, which is stiffer and it's easier to handle for pupils that are small. So you can see now I'm going to latch on the trailing part of the iris, and I like to use a Coughlin hook here so that I do not stretch the pupil extensively or push the leading scroll into the angle. And this is after the surgery is done. We remove the ring before we remove the viscoelastic, compress the lateral scrolls as they come through. Now this patient has practically a really small or almost no pupil, and we have to just pick out exactly where the pupil is. Again, I like to remove membranes, and now we can see exactly where we should be lysing the adhesion just using scissors, and I'm able to cut to create that pupil again, picking out any membrane that I can remove. And once that's reasonably unbound, I then inject a Malugin ring. And you know, when I started injecting this Malugin ring version 2, which is made of proline 5O and is less sturdy and more difficult to direct, I was really regretting because this had been such a small pupil, and actually using iris hooks may have been the wiser decision. So you'll see here, I'm trying to get on this scroll, and it's a bit harder to do because the proline is really quite malleable. So in this case, I use microforceps, and you can see when I punctured the capsule, the staff also appeared telling me that I really need to insert a capsule tension ring at the end because the zonules are loose, and it's not uncommon in chronically inflamed eyes. So the IOL goes into the bag before I remove the Malugian ring, again retract, compress the lateral scrolls as they come through, and this then comes out quite easily. So at the end, I injected dexamethasone into the anterior chamber to reduce post-op inflammation. In the case here, where the capsular axis had not been large enough, it's important at the end, you can insert the lens first, or you can do the enlargement of the capsular axis at this stage. But it's important to do this to prevent capsular phimosis. Polishing the anterior capsule also helps. So in this case here, I also injected a capsular tension ring before inserting the IOL. The pediatric eye is far more difficult. We should consider the role of primary posterior capsulotomy with anterior vitrectomy when we're dealing with patients who are 8 years or less. I usually give intraoperative preservative-free triamcinolone during vitrectomy. It significantly reduces postoperative anterior segment inflammation and also provides enhanced visualization of the vitreous during vitrectomy. And the choice of IOL remains a contentious issue, as was already discussed previously, and most would avoid an IOL definitely in the uveitic eye in a child below 2 years of age. So this is a patient with VKH. When he came to me, he was already having white cataracts, and we took some time to control an inflammation. In the meanwhile, he developed extensive peripheral anterior synechia with all the membranes, which I'm now removing. And you can see a white cataract there. So after releasing the peripheral anterior synechia, I'm sweeping on the posterior synechia to release it. And I realized it's really not just at the pupil edge, it's so broadly adherent. So I just expanded the pupil to a reasonable size so that I can remove this lens, which just nearly needs aspiration. It's a child. So after staining and removing the capsule, I then aspirate. And you can see the red sunset glow fundus reflects there. I puncture the posterior capsule, and then with a 27 gauge needle initiate a posterior capsulotomy. You can use a vitrectomy machine to do this. Stain with triamcinolone acetonide diluted. I usually like to about a third, and then do that limber approach for anterior vitrectomy, making sure I don't leave any strands of vitreous, and then leave this patient aphakic, because you can see this eye, I was having difficulty controlling the inflammation. And this patient is now more than 12 years of follow-up, and he's doing pretty well. So sometimes we do have patients who have a big pupil, and a big pupil is also not good, especially when they go out, they get glare, they have difficulty reading. So in this case here, this patient has herpes zoster, and a single episode caused the sphincter to be grossly damaged. And after staining with vision blue, injecting a capsular tension ring, and inserting the IOL into the capsular bag, usually the capsulotomy should be about 5.5 mm to insert this artificial iris without fiber into the capsular bag. I trefine, usually about 9.5 mm for a standard size eye, and 10 mm if the patient is having axial length of more than 26 mm. For a high myope, I fold this into 3, or today I prefer to inject this with a viscojet injector through a 2.2 mm inserter, and this goes into the capsular bag. So staining the capsule helps visualization and enables the iris to be inserted in front of the IOL into the capsular bag, and then we suture to ensure that this patient doesn't have any leakage of the wound post-operatively and causing the iris to come forward. And you can see this is his result. And he was very happy because he had no longer the glare and he had no difficulty reading. So these are the surgical pearls I want to leave with you. When there's peripheral anterior synechia, always release that before posterior synechia, as the posterior synechia holds the iris taut as you release the more tenacious peripheral anterior synechia. So lice posterior synechia with a coughlin, just with a cannula that's loaded near viscoelastic just by sweeping. And for the synechia that's closer to the incision, it can be difficult. So you use a coughlin hook, which is extremely useful. If they're pupillary membranes, I always like to release them because it allows the pupil to unbind and to enable surgery as well for the pupil to dilate post-operatively so that we can examine the retina easily. Expand the pupil by stretching, cutting, or using devices like what I showed. If it's not really very easy to stretch the pupil, patients with small eyes, shallow anterior chamber, I would prefer to use an iris hook to a device like a Maruchan ring that has a fixed pupil expansion size. I generally always inject intracameral dexamethasone 0.4 milligrams in 0.1 mil at the end of the surgery as long as it's a non-infectious uveitis. This helps to control the inflammation for 48 hours after surgery. Thank you very much for your attention.
Thank you, Professor Chi, for the wonderful surgical pearls. With this, we now move on to our next speaker, Julio Gonzalez Lopez. He could not join us today, so he sent his recorded talk. Julio is from the University of Alcalá, Madrid, Spain, and he'll be talking on yet another challenging topic in uveitis, cataract and JIA, special considerations.
Good afternoon. My name is Julio González. I'm a uveitis specialist from Hospital Universitario Ramón y Cajal in Madrid. I would like to thank the IUSG for the opportunity to be here with you in this webinar this afternoon. And I beg you my apologies as I have not been able to attend live. In this short talk, we will be speaking about cataract surgery in patients with juvenile idiopathic arthritis. We will start by reviewing the condition juvenile idiopathic arthritis and the risk of chronic anterior uveitis associated and the risk of developing cataracts in this patient. We'll move on to speaking about preventing cataract development. And once we have the cataract developed, we will speak about preoperative management, surgical technique, IOL selection, and postoperative management of patients with juvenile idiopathic arthritis and cataracts. Finally, we'll wrap up with some take-home messages for you. As you know, juvenile idiopathic arthritis is a group of autoimmune diseases that are characterized by the presence of idiopathic arthritis that lasts longer than 6 weeks in patients younger than 16 years old. The most accepted classification is the one developed by the International League Against Rheumatism that separates patients with juvenile idiopathic arthritis in 7 categories, which are systemic arthritis, oligoarthritis, polyarthritis that can be rheumatoid factor negative or rheumatoid factor positive, psoriatic arthritis, enthesitis-related arthritis that behaves very much like B27 positive conditions, and finally, those who cannot be classified in any of these categories are set in the last category, which is undifferentiated arthritis. Recently, the PRINTO group, led by Alberto Mandini, proposed a new category, which is the early onset ANA positive juvenile idiopathic arthritis, which is interesting because most of the patients we see in our uveitis clinic will come from this new proposed group. However, this is still on evaluation, and whereas most of these patients will come from the oligoarthritis and undifferentiated arthritis categories. The risk factors for developing uveitis in patients with juvenile idiopathic arthritis are the female sex presenting with oligoarthritis, having positive ANAs in 2 separate determinations, onset in younger than 4 years old, rheumatoid factor negative, and the presence of HLA-DRB1. Taking this into account, there is a recommended uveitis screening. This is important because These patients often will not refer any symptoms until they have developed important sequelae. So patients, once they are diagnosed of juvenile idiopathic arthritis, need to be screened for uveitis. Patients with lower risk, with the absence of risk factors, like for example patients with systemic JIA, polyarthritis, rheumatoid factor positive, and enthesitis-related arthritis, are considered low risk, and those can be screened every 6 to 12 months. Whereas patients with ANA positive, JIA with age of onset less than 7 years old, and disease duration for less than 4 years, those patients with osteoarthritis, rheumatoid factor negative polyarthritis, psoriatic and undifferentiated arthritis, are considered high risk and will need to be screened every 3 months. If these same patients with osteoarthritis, polyarthritis, or psoriatic undifferentiated do not have positive ANAs, start their condition older than 7 years old, or have a disease duration of more than 40 years, they can be considered low risk and they can go on to be screened every 6 to 12 months. So cataract development is one of the most frequent complications of patients with juvenile idiopathic arthritis associated chronic anterior uveitis. The incidence is not very high, it's just 0.04 per eye and year, but taking into account that the disease is chronic, the prevalence goes up to 90 to 80% and varies a lot between series. Older series seem to show higher prevalence. More recent series show lower prevalence, probably because of the changes and management of systemic inflammation, as we will see next. It is important because cataract may develop at an early age, and that may lead to amblyopia risk and may lead the patient to have low vision in their eyes for all their lives. So what are the risk factors? The risk factors are presenting with a lot of inflammation, especially if the patient already has posterior synechia diagnosis, and we are not able to control the inflammation. The patient has active and ongoing inflammation. And other risk factors are the use of corticosteroids, whereas systemic or topical, especially if the topical corticosteroids are used more than 3 times daily, we are inducing a risk of developing cataracts for that patient. So how can we lower that risk? How can we prevent cataract development? We can do that by screening correctly and screening often, especially those patients with high risk, and using steroid-sparing agents. Those can be the classical, like for example, methotrexate, azathioprine, or mycophenolate. We can go for biologic, which are very, very useful, and I think we're switching them to be first line more and more often nowadays, like infliximab and especially adalimumab. And potentially, for those who do not respond to previous medications, biologics and methotrexate, JAK inhibitors can be useful as well. There's still research going on, there's still research needed to prove that, but I think we can, in the next few years, we will be able to say that JAK inhibitors are also able to decrease the need for steroids in this patient and decrease the risk of cataract development. So once we have the cataract's already there. The first question is, when do we operate? Do all patients need to be operated? Well, I think in my case, it has been shown that is also the opinion of other specialists, we tend to operate when the visual acuity goes worse than 20/40. Seems a reasonable cut point. In order to operate, we need the eye to be quiet, and we need the uveitis to be quiescent for at least 3 months before surgery. Operating on a hot eye or operating on an inflamed eye will lead to poor visual result in the patient, and we do not want that. There has been some discussion on whether to stop immunosuppressive medication before surgery, because especially for orthopedic surgery, this patient has shown that patients that were on immunosuppressive medication had a higher risk of infection. However,
A recent survey done by our French colleague has shown that if we stop immunosuppressive medication, there's a high risk of flare-up, a high postoperative, difficult to control inflammation. And we do not clearly lower the endophthalmitis risk because when we use intracameral antibiotics, the endophthalmitis risk is minimal. So it is preferred not to stop immunosuppressive medication before surgery. Is there a need to intensify preoperative medication? Classically, it was done in the pre-biologic era, but it's not so clearly needed nowadays. In the same French survey published in 2021 that I cite here in this slide, only 28% of the surgeons use preoperative intensification. It can be done if you think it will be useful for your patient. Usually with 1 week of topical or systemic steroids is enough in order to prevent this postoperative inflammation. About the surgical technique. Surgical technique is similar to another cataract, but with some specific difference. First off is the presence of synechiae. I usually go with a blunt synechiolisis with the viscoelastic cannula. With that is usually enough to separate the iris from the anterior capsule of the crystalline. Oftentimes you will find that in spite of the synechiolisis, the pupil is still small and iris retractors may be required. My tip here is that you think that you will need iris retractors, use them. If you think about them, use them, because you will not regret of having used the iris retractors, but you will often regret not having used them in the first place. So if you think about them, use them. About the implant, that was also discussed in the past, whether to leave the patient aphakic or do a primary implant. This recent meta-analysis has shown that patients that received a primary implant ended up with better corrected visual acuity, both in the short term and the long term. So I think the answer here is yes, do a primary implant. There is less hypotony risk when we compartmentalize the eye with the implant. However, there is more opacification of the visual axis. As you see here in the same meta-analysis, the hypotony risk is less for the patients that receive primary IOL, but the opacification is up to 10 times more frequent in patients that had the implant than those left aphakic. So there's something we need to think about. So now we have chosen to go for a primary implant. Which IOL are we going to use? First of all, let me talk about the material. We need to avoid silicone IOLs because they have a higher risk of postoperative inflammation. Hydrophobic acrylic IOLs have shown to have less postoperative inflammation, and in my opinion are the lenses to go with. If you can, use hydrophobic acrylic IOLs. If this is not available, heparin-coated PMMA IOLs are an acceptable alternative and have shown also a low risk of inflammation. So if you can, use hydrophobic acrylic. If you cannot, try going for heparin-coated PMMA. And what power to use? Well, formulas here are similar to those used on pediatric cataracts. Studies, especially this very recent meta-analysis, have shown that the lowest error can be obtained using the Barrett Universal 2, SRKT, and Holiday 1. So try using these three formulas. Kane formula may be acceptable as well for very short eyes, so take that into account. But for most of the eyes, you will go right using these three formulas. And now the next question is, which target refraction are we aiming to? There's a discussion whether to leave the patient aphakic or leave them hypermetropic and allowing them for the eye to grow into a metropia when our patient grows. So discussing this with my pediatric ophthalmology colleagues, what we usually advise is leaving the eye hypermetropic. The patient will be controlled in person. We will take care of the refraction required and treatment of amblyopia. So we're going to leave them hypermetropic and allow the eye to grow into emetropia. So rule of thumb here is that the age of the patient and the target refraction will sum 7. So if we have a 3-year-old patient, we will leave them 4 diopters hypermetropic. If we have a 5-year-old patient, we leave them 2 diopters hypermetropic. For patients 7 years until puberty, we allow them to 0.5 diopters of hypermetropia, and patients puberty and onwards, we will aim for emetropia. The following question we have is, we have seen that when we do a primary IOL implant, we have 10 times higher risk of posterior capsule and anterior vitreous opacification. So do we do a primary posterior capsulorhexis and anterior vitrectomy? And again, this can be discussed. There's no right or wrong answer here, but most specialists, 49 to 75% of the specialists, will choose to go for primary posterior capsulorhexis and anterior vitrectomy. How do you do that? Well, I'm a vitreoretinal surgeon. I usually opt for a post-plana approach. I put the lens in the bag, and I'm sure that the lens is in the best place possible, and after that, through post-plana, with a cutter, I will do the posterior capsulorhexis, open the anterior hyaloid, do a core and anterior vitrectomy. There's no need to induce a PVD. The posterior hyaloid is very stuck to the posterior pole in those patients. It's difficult to induce a PVD, posterior vitreous attachment. So my advice is just do anterior and core vitrectomy. It can be done also by an anterior vitrectomy approach. However, you need to do the posterior capsulorhexis before putting the lens in, and there's a higher risk that the lens may end up in the sulcus, which is not a bad place, but in my opinion, having the lenses in the back is much safer. For the postoperative management, advises use a lot of steroids and taper slowly. As I often do the post-plana vitrectomy, and most of these patients, because of their age, they go on general anesthesia. But in spite of the general anesthesia, after the surgery, I do a subtenon incision for putting some top-up of local anesthesia. So when the patient wakes up, the eye is not painful. And through that same subtenon approach, I will inject some triamcinolone. And that triamcinolone will make sure that the eye is quiet during the postoperative period. Using of implants, like also that implants has been described as well, can be useful. But the most important thing in these patients is watch for the IOP response. Children tend to do very high IOP responses when exposed to local steroids, and we need to watch for that. And most of those IOP responses can be managed with topical medication, but they need to be seen frequently after the surgery. Complications that may arise are flare-up, macular edema. Most of them can be dealt with both with local steroids and increasing the systemic therapy. Most of the times what we would do is increasing the dose of the therapy they are already with, but if they do not, if the macular edema does not respond, we can consider using tocilizumab. We have found that tocilizumab is very effective for dealing with macular edema. And if you have not done the posterior capsulorhexis and anterior vitrectomy, you may end up with visual axis opacification. It doesn't happen all the time. Patients that are very well controlled may not present it, but it's very, very frequent. So when it happens, my approach is go for post-plana vitrectomy and posterior capsulorhexis, but always do it in a quiet eye. Do not operate on a hot eye, do not operate on an inflamed eye, because the visual results will not be good. The patient will not end up with a good vision, which is what we want. We do not want only a clean visual axis. We want the patient to see better than before he underwent surgery. So this is the conclusion. Prevent cataracts, screen the patient often, and remember that the mission is remission. Do not tolerate any inflammation in patients with juvenile idiopathic arthritis, because that will lead to sequelae. When to operate? You need to have an eye that has been quiescent for 3 months or longer before going into the operating room. and with a vision that has become lower than 20/40 or 6/12. And how do you operate? My advice, use a primary IOL implant, and when possible, choose an acrylic implant. And if you think that you will need it, use it. Use iris retractors if you don't think you'll be able to operate with a small pupil. And do posterior capsulorhexis and anterior vitrectomy. For me, the way out is the easy way out. So put the lens in the bag, and after that, go behind the lens and clean the visual axis. Thank you very much for your attention. My apologies once again for not being able to attend live, but if you have any questions, I've leave you my email address here, and I'll be more than glad to answer them for you. Thank you very much.
So thank you, Julio, for being so kind to send your recorded talk despite not being able to be with us. So thank you very much. And every time I introduce the speakers, the esteemed speakers of uveitis from all over the world in this webinar, it's an honor for me every time I introduce them. And I thank IUSG for that. So again, now it's a personal honor for me to be introducing our next speaker, Professor Ramod Gupta, who needs no introduction, who's been my chief, my mentor, and he has mentored several students from this part of the country, including Dr. Vishali, who continues to carry on his legacy in the field of uveitis and vitreoretina. Thank you, sir. So Professor Ramod Gupta is the founder of Advanced Eyes Center, PGI Chandigarh, India, which is one of the leading institutes in ophthalmology in the country. He's the Professor Emeritus from Advanced Eyes Center and has been the Dean of the Institute during his tenure. With his vast contributions in uveitis and vitreoretina, especially in ocular tuberculosis and diabetic retinopathy, we have a very apt combination today for him to be speaking on vitreous surgery in uveitis. And no doubt he's known as the father of uveitis in India. Over to you, sir.
Well, thank you, Rima. Friends and my fellow panelists, I'm extremely thankful to IUSG for allowing me to share some of my experiences of doing microincisional pars plana vitreous surgery in patients with uveitis. I'm sorry for a little challenge here. Not able to get my screen here. Yeah, now you will be getting my presentation. I'm sorry for this. So, as you are all aware that medical treatment of non-infectious uveitis is highly effective, and we typically use high doses of corticosteroids to douse the acute inflammation and maintain the control with a variety of strategies to use steroid-sparing medications. Ever since Diamond and Kaplan back in 1978 pioneered the use of pars plana vitreous surgery to manage some of the complications of non-infectious uveitis. There have been an increasing number of reports now in literature for the last more than 40 years of using vitreous surgery for a variety of complications of uveitis, including media haze, vitreous hemorrhage, cystoid macular edema, macro hole tractions. More importantly, whenever you come across a patient where you strongly suspect an endogenous endophthalmitis, you need to do an urgent vitreous surgery, or as we have seen in patients with CMV retinitis or acute retinal necrosis, almost 40 to 45% of the patients may go on to develop rhegmatogenous retinal detachment, as seen in this particular patient of a renal transplant patient, young man who developed a chicken pox followed by acute retinal necrosis, which was bilateral, and subsequently developed rhegARD, which was repaired. So these are some of the cases which we are very much familiar for the use of vitreous surgery in uveitis. Now, what I'm sharing here is our experience, which is one of the largest series of doing a diagnostic therapeutic vitreous surgery among patients who posed us a diagnostic challenge, mostly for majority of them were posterior uveitis, and some of them were intermediate or pan-uveitis. These patients had been suffering from uveitis for a median of about 12 months, and the interval varied from 12 months to almost like 3 months to 34 months. And following surgery, we did follow them up for a median of about 13 months. Now, what have been the indications for doing such an invasive procedure? Whenever we faced with atypical clinical presentations, especially of posterior uveitis, or cases who did not respond to our empirical treatments, and or there were certain instances where the disease progressed rapidly, and we had inconclusive non-invasive workup. Of course, I'm sure most of you are familiar that if we have a strong suspicion of malignancy or masquerades, we need to do pars plana vitreous surgery. Most of these patients we subjected to the vitreous fluids obtained, which was undiluted, to a variety of microbiological, immunological, nucleic acid amplification, cytopathology, and cytokine workup as and when we felt it was required. Now, I'd like to share some of these patients. Now, this is a 25-year-old woman who has been symptomatic for 12 years. She has tuberculin skin test positive, 20 millimeter, but CT test is normal. As you can see here, she has extreme media haze, and she has just a corner finger positive vision. She was subjected to vitreous surgery, microincisional vitreous surgery using a 23-gauge vitreous surgery. And you can see right on day one, we're surprised to see her vision acuity improving to 618. And by the time it was more than a year of follow-up, she maintained that 618 vision. Not only that, the vitreous fluid obtained from her, we did the polymerase chain reaction for MTB, it was positive, and she was treated with anti-TB drugs so that we could achieve this kind of a, outcome in this patient only by doing invasive MIVS. For this particular patient, a 23-year-old man, again, has a tuberculin skin test positive, but X-ray radiology is normal. This patient has bilateral multifocal healed serpaginoid-like choroiditis, and left eye particularly, he has a couple of granulomas in the posterior pole. Again, the visual acuity is just reduced to hand motion because of media haze, because of the CME, and the whole lot. And this patient was subjected again to MIVS, and you can see within a week, the visual acuity has improved to 660. The granuloma has responded by showing a significant decrease in the size, and by about 3 months, it has all completely disappeared and healed. In this particular patient as well, the PCR for MTB from the vitreous fluid was positive, and the patient underwent a definitive. So MIVS has led us to use for initiating a definitive treatment in some of these cases. Now, this was a guy who was referred to us. He was in acute depression because he had been going around around India for about 7 months. He had been treated on IV methylprednisolone. He had received oral high doses of prednisolone without any relief. And currently, when he reached us, he was already on methotrexate, 15 milligram per week. His visual acuity is reduced to 3/60, and he has significant vitritis. As you can see here, he has extensive healed as well as active patches of multifocal serpaginoid or serpiginous-like choroiditis. And we confirmed this when we did the autofluorescence, the hyperautofluorescent areas. On fluorescent angiography, you can see multifocal hypo areas you can see all over, which become hyperintensely hyperfluorescent in late frames, indicating the disease was very much active. Since this patient has been on treatment for a long time, we advised him to undergo MIVS, which we did the next day. And this, we like to do microincisional vitreous surgery under air so that we can obtain undiluted vitreous fluid almost to the extent of almost 1 ml. Then when we switch on the infusion, you can see within a week of the surgery, already his active lesions have started healing. And by about a month later, by about 4 weeks, the lesions have practically healed. We did his PCR for all the viruses, which were negative. The gene expert for MTB was negative, but his multiplex PCR for MTB was positive. We did a gene sequencing to see if this genome was MDR or rifampicin sensitive. We found that, well, this genome of MTB was rifampicin sensitive, and he was started at this point of time about a month after the surgery was put on anti-TB drugs with corticosteroids. You can see at this time the lesions have practically healed, and we followed this patient, and you can see 3/60 when he first presented to us, and we went back very happy, 6/6 vision in about 8 months' time when I last saw this patient. Now, similar kind of response in patients of tubercular uveitis, therapeutic response in resolution of vasculitis, therapeutic response in granulomas, as well as serpiginous-like choroiditis has been reported in a series of 30 patients by the Hyderabad group led by Soumya Basu. Now, this was another puzzling patient, 24 years male, who had undergone retinal surgery, pars plana vitreous surgery for, you can see the drainage site, drainage site. And the right eye at this point of time was normal. This patient was followed up. A year later, he came, his right eye was normal. But 3 years after this presentation, he came back with loss of vision in the right eye. At this point of time, we find that he has vitreous inflammation, he has optic disc edema, he has perivascular cuffing here. And when we looked at the periphery, he has these retinal retinitis patches. And these patches, as we followed this patient the next few days, they showed a rapid progression in a circumferential manner. He underwent diagnostic PPV, and we found that the vitreous PCR were positive for HSV. He was managed on valcyclovir, as you know, they need to be treated for a long time, and was followed up. And you can see the year later, he maintained 6/6 vision. The lesions have all healed, and it's a very happy outcome following this surgery. This was another 39-year-old person who presented to us with symptomatic for 10 days in the right eye, and he has very significant vitritis, right more than the left eye. The visual acuity is reduced to just count a finger in 6/9. Now, interestingly, he was actually B27 positive. He had received anti-TB drugs 2 years ago. He has passed blood in stool 6 years back. He had hepatomegaly, splenomegaly. ANA was positive, and lo and behold, his HIV was also positive. So we subjected this patient to vitreous surgery because we didn't know what we were dealing with. This patient had a picture of intermediate uveitis primarily, and it's a kind of a non-necrotizing presentation. And we found that this PCR was positive for HSV. And this, we could initiate a definitive antiviral therapy on this patient with a very happy outcome. Another lady who presented with bilateral peripapillary or juxtapapillary necrotizing retinitis and was symptomatic in the right eye for about a month and about 8 days in the left eye, had just counting finger vision. We didn't know, because this patient we detected to have HIV for the first time. We detected CD4 count was low. We didn't know what kind of infection is this. Is it a viral? Is it a toxoplasma? And when we did the vitreous surgery in the right eye, we found that she was positive for both. So it's not uncommon to have mixed infections in patients that are immunocompromised, especially the HIV patients. And we treated her on intravitreal clindamycin. That was a standard treatment at that point of time, as well as antiviral therapy with a very happy outcome. And she recovered very nice vision, as you can see, the healed lesions in both the eyes. This was a patient again posed as a major challenge, a 66-year-old man. He had actually been treated for 6 months or more with high doses of oral corticosteroids, posterior subtenon injection of Kenalog, and also received intravitreal Kenalog in the past without any resolution of these lesions. The key to the diagnosis or suspicion that we were dealing not with uveitis, but primary vitreoretinal lymphoma was this kind of appearance. You can see a leopard skin appearance on fundus fluorescein angiography. And of course, the OCT was highly characteristic, showing the sub-RPE deposits of this amorphous material, hyperreflective. Again, this patient underwent, and the point I wish to highlight here is that this amorphous sub-RPE non-adherent the cellular deposits can be easily aspirated through a 25-gauge soft tip cannula and subjected to the cytopathology. Here, the cytopathologist has to be on alert that we are submitting a sample to him so that it can be processed within minutes, has to be transported in cold medium or in a cold thermos. And this patient was diagnosed B-cell lymphoma based on the cytopathological features. And you can see here, since we suspected this patient to be lymphoma, we gave the first injection of intravitreal methotrexate right on the table. And you can see within a couple of weeks, this lesion is showing a resolution. This is a point-to-point registration on OCT. And as you can see, within 2 weeks, the lesions are practically disappearing. You can see the residual air bubble as yet in the eye. And within 6 months, he's recovered fairly good vision in this eye. Now, what we found in our experience was that the pars-plana vitreous surgery led to a definitive diagnosis in more than 50% of the eyes. Interestingly, we had preoperatively thought of tuberculosis as a possible etiology in nearly 2/3 of our patients, but we could confirm it post-operatively during by PCR from the vitreous fluid in only about 44 of these patients, or 2/3 of these patients who we initially suspected to have TB were confirmed by PCR. And then we had sundry cases of viral or PVRL or toxoplasma and syphilis, and some of these patients could be confirmed by doing a variety of tests. Now, what struck us the most was, contrary to the popular belief that vitreous surgery may lead to deterioration in vision, here we found right from day one, when we compared the pre-op to the post-op vision acuity, invariably the visual acuity improved and continued to improve till our last point of follow-up about 12 months, and there was a substantial, significant improvement in vision. And more importantly, and I think this will be very interesting to note, that pars-plana vitreous surgery led to discontinuation of corticosteroid therapy in almost 50% of the patients, and nearly 86 patients out of the cohort of 103 patients were already on corticosteroids when we did the pars-plana vitreous surgery, and we could almost like 50% of the patients, we could stop altogether the use of corticosteroids. And in other cases, we could bring down the dose substantially below the safe limit of 7.5 milligram. Of course, as expected, we did have our own share of complications, specifically cataract, as was expected, and as Lucia pointed out, that vitreous surgery leads to increased oxygen concentration in the vitreous cavity, which is responsible for cataractogenesis, and that's what we found, that this was seen in almost 14% of the patients, and it was a late complications. We did see the raised intraocular pressure, which could be managed with topical medical therapy, and almost again about 13% of the patients. Mild vitreous hemorrhage was seen in about 5 patients, and what worried us the most was the hypotony which developed early in the course of our prospective study, because mistakenly we believed that microincisional vitreous surgery is a sutureless technique. It's not a sutureless technique, and I want to form it again, that microincisional vitreous surgery in patients with uveitis, we need to put a suture on any port that we suspect to be leaking, and the eyeball must be inflated at the end of surgery and not leave hypotenuse, because we might have disastrous complication like choroidal detachments. We did have patients who developed retinal detachment, and very impressively, only one eye showed a deterioration in the inflammation or worsening of inflammation. Out of 106 eyes, only one eye got that kind of. So I think this we've shown from our study that it's very, very safe procedure to do with the current technology, the instrumentation that we are available. And we don't have to harp on quiescence of the eye as we do for cataract surgery for obtaining reasonably good results. In majority of cases, you could stop corticosteroid because you do get to have a definitive diagnosis. And here, most of these cases, as you would have realized, have been done for not for non-infectious uveitis, but for where we had a strong suspicion of infectious uveitis, be it span uveitis, posterior uveitis, or intermediate uveitis. As I said, the hypotony and choroidal detachment is a challenge, and subsequently these patients did well, but it does give you, for a week or 10 days, it gives you a sleepless night in a patient who's already seen from that eye. Retinal breaks and RD for any retinal surgery would be a reasonable expectation, and this happened in a very, very small number of patients, just about 3 patients. But the most importantly is the negative labs, which can be a very daunting experience if the laboratory investigation reports come negative and not conclusive. In summary, I would like to suggest that microincisional vitreous surgery can be recommended for patients who have atypical presentations, especially those who are immunocompromised or because of HIV or primary immune deficiencies or immunosuppressive therapy for whatever reason. And those patients, and this we have seen repeatedly, not responding to your empirical therapy. Do not wait. These are hot eyes. Do not wait for your therapy to work. Go in, take out vitreous samples subject to a variety of tests. It's from our experience and those reported by Soumya Basu and others in literature in recent years, it's very well tolerated despite presence of significant inflammation in the eye. It's safe, and as I've shown you, it's a very, very effective therapy in uveitis. And as I've shown you, the experience in TB granulomas, in vasculitis and choroiditis, serpiginous-like choroiditis, it has a salutary effect, perhaps by removing the cytokines, also eliminating the CD4 helper T cells, which are specific to the retinal antigens as well as the TB antigens, as well as these are the. Once you remove them, eliminate them through vitreous surgery, the drive to inflammation may be kind of significantly reduced or eliminated, bringing about a resolution of these posterior segment lesions. Diagnostic, however, should be done, I would suggest, only if your center or if your clinic has expert lab facilities available nearby you. Thank you very much again for this opportunity.
Thank you so much, sir, for a complete overview of vitrectomy in uveitis and for bringing clarity to many issues that are raised by the uveitis experts, especially in the field of vitreous surgery in uveitis. So thank you, sir. And with this, we now move on to the last talk of this webinar. We now have Dr. Sofia Andrauri, who's an associate professor of ophthalmology, University of Thessaloniki, Greece. She also is affiliated with the University Hospital of Larissa and Interbalkan Medical Center. And Dr. Sofia would be talking on managing eyes with cataract and hypotony, and yet another challenging subject in uveitis.
Thank you so much. I feel extremely honored to present in this IUSD webinar, and I would like to thank the IUSD and Professor Visali Gupta for this kind invitation. My topic is managing eyes and cataract with cataract and hypotony. It's a difficult topic that I always wish I hear from others. This is the list of my financial disclosures. None of this is relevant to this presentation. In ophthalmology, in particular, in uveitis, we often have to deal with hypotony, which to my view is much more difficult to manage than a high intraocular pressure. Ocular hypotony is a potential vision-threatening complication, and it can be acute or chronic. And although controversy exists regarding the cutoff intraocular pressure, for the definition of hypotony, it is generally considered as an average of 5 millimeters of mercury in 3 consecutive measurements. Hypotony has also been defined as in other publications as a cutoff of 6.5 millimeters or less. Ocular hypotony can be clinical or not clinical, depending on the occurrence of clinical features. It's not clearly who will develop clinical signs of hypotony, and some patients can tolerate long periods of hypotony without loss of vision. So the clinical definition of hypotony is intraocular pressure low enough to result in vision loss. The vision loss from low intraocular pressure may be caused by corneal edema, astigmatism, maculopathy, and fundus abnormalities in the form of chorioretinal folds, optic nerve head edema, and vascular tortuosity. Hypotony can occur with either increased outflow, for example, via a filtering bleb or overfiltering bleb or cyclodialysis cleft, or a decreased aqueous humor production by ciliary body shutdown, as in the form as it may happen in inflammatory conditions and uveitis. With the onset of hypotony, the scleral wall collapses inward, resulting in choroid and retinal redundancy, which gives the characteristic chorioretinal rigging, as you can see here. The anteroposterior diameter of the eye shortens, and this is manifest as a hyperopic shift. Anterior bowing of the lamina cribrosa in the optic nerve leads to restrict axoplasmic flow, causing disc swelling in the acute phase. Patients with advanced optic nerve disease may not show optic nerve edema as they have fewer viable nerve axons. These are the listed cause of a decreased aqueous humor production or increased aqueous humor drainage. And for uveitis, you can see that chronic uveitis, and in particular JIA, with almost 60% of cases, they can manifest as hypotony secondary to scarring or traction of the ciliary body. Also, systemic medications can cause hypotony. Carbonic anhydrase inhibitors, antihypertensive nitrates, antivirals like cytofovir, but also systemic causes like pregnancy, dehydration, uremia, diabetic coma. Uveitis-induced ocular hypotony is reported to occur after anterior uveitis, non-infectious anterior uveitis, or panuveitis. The risk of ocular hypotony is higher after anterior uveitis and panuveitis. A diversity of mechanisms are responsible for the ocular hypotony, and these are include but not limited to acute ciliary shutdown, leading to decreased aqueous humor production, ciliary body detachment, atrophy of the ciliary pressures, or increased uveoscleral outflow. To manage the uveitis-induced acute ocular hypotony, we have to treat aggressively the active inflammation, and this is essential to restore vision and prevent ocular complications. Patients may complain of distorted vision, or they may have no symptoms at all. But take note that in cases of hypotony, this is perhaps the trickiest symptom, the accelerated cataract formation. And in a patient facing hypotony, visual significant cataract induces even more variables and challenges. And here I will offer some suggestions for managing these patients. And the $1 million question is, what is the optimal approach for these patients? First, you have to wonder yourself, is this really hypotony? Is your patient really hypotonous? The numerical threshold of 5, as we mentioned before, doesn't reflect the realities that some patients may have lower pressure measurements, but don't have any ocular complication due to the low intraocular pressure. The presence of symptomatic hypotony is indicated by clinical signs such as decreased vision, hypotonic maculopathy, as you can see on OCT, and sometimes choroidal effusion or choroidal falls. But if your patient has a low intraocular pressure, let's say 3, a visual acuity is 20/20, your patient is happy and doesn't have any visual distortions, so the patient, this is not hypotony, your patient is not a true, is not in danger. So whether or not any signs of hypotony appears seems to depend on how much a given eye can tolerate a given pressure. That means that hypotony is very patient dependent. And once you have decided that a patient intraocular pressure is really lower than it should be, then this is the next question. How long has the patient been hypotonous? Because if it's chronic, it's more than 6 months or a year, then there may be some irreversible components to the hypotony, especially the hypotonic maculopathy. And if this maculopathy is present for a long time, the odds of a perfect outcome are diminished. So you need to make that clear to the patients and set the patient's expectation appropriately. This is a case that was referred to me of treating hypotony post-valve in the right eye that was referred to me for treatment of the patient's macular edema. The fluorescent angiogram to the right can enlighten the treating physician, disclosing the characteristic pattern of hypotony with a striking alternating dark and light bands in the retina due to the thinning of the RPE. So the question here is not to treat a macular edema, but to treat hypotony. And another question, should I address the hypotony before, during, or after the cataract surgery? So in a case of severe hypotony, it's better to address the hypotony beforehand to ensure the accuracy of intraocular lens calculation and maximize surgical safety. We know that the axial length of the eye can increase when the intraocular pressure increases. That means if you measure the axial length for a biometric calculation before addressing the hypotony and the pressure is normalized later after cataract surgery, then you will have a myopic surprise. For instance, in an eye with low pressure, a 3 mm shorter axial length secondary to hypotony will result in 8 diopters stronger intraocular lens after the hypotony resolves. The other thing that can be altered by hypotony is the corneal shape. Keratometry readings can vary significantly, and as a result, you have to be very wary of implanting toric lenses when measurements have been made in the presence of hypotony. The bottom line is, if the patient has significant hypotony and you are starting from very low intraocular pressure, I'd recommend addressing the hypotony first and performing cataract surgery later. You will end up with much more accurate preoperative measurements and predictable outcomes and safety in your surgery. There will be a situation in which the pressure is just a little low and the patient doesn't have maculopathy or visual distortion. In that case, I might decide to wait and address the intraocular pressure during or after the cataract surgery to avoid having to take the patient to the OR twice. Preoperative assessment entails the need to identify the exact cause of hypotony, to make sure that the cataract surgery is going to improve the BCVA, so absence of hypotonic maculopathy. You have to do multimodal imaging to assure that. You have to attempt to correct the hypotony, first the hypotony conservatively, and I will talk about this in a moment. And you have to have set realistic expectations for you and your patients. We use the multimodal imaging, and very useful is the UBM, which helps us in further evaluation of the anterior chamber depth and iris contour and visualization of anatomical structure posterior to the iris. We see the position of the ciliary body. To the left here, you see anterior extension of cyclitic membrane towards the lens and the ciliary body. And to the right, you see the cyclitic membrane behind towards the intraocular lens. So this is the true cause of hypotony. OCT helps to confirm the diagnosis. Sometimes hypotony can be very subtle and you cannot appreciate that only through biomicroscopy. and help you monitor the outcomes after various types of intervention. It may detect the wrinkling of chorioretinal folds in the posterior pole that may be difficult to assess, and furthermore, OCT has been shown to detect pathology in the presence of a normal ocular exam. You have to carefully view all the radial scans of the OCT, and this is very important not to miss anything. Fluorescent angiogram may also reveal the leakage from the optic nerve head in the acute phase, and B-scan can help you appreciate the choroidal thickening and choroidal or retinal detachment in case you don't have a clear fundal view. Options for treatment include systemic steroids and non-systemic antisteroid drugs, topical steroids including prednisone acetate, difluprednate, non-steroidals, and local injection of steroids including triamcinolone acetonide, peribulbar, transeptal, triamcinolone, and methylprednisolone. Cycloplegic agents, atropine, help treat ocular hypotony and provide posterior rotation of the ciliary processes, maintaining the anterior chamber depth. Topical ibopamine, this brand name is Trazil. It's very difficult to find, but has been reported to work very well in patients with uveitis. I've tried this myself, but it's very difficult to find. Injection of OVD has been used to treat ocular hypotony. Intracameral injection are often employed post-op to treat or prevent flat anterior chamber. And not to forget systemic immunomodulatory therapy to manage the primary inflammatory condition. Steroids have been used with good effect in case the hypotony is caused by ciliary body shutdown, and don't be afraid to give it locally or even intravenously. Sometimes the local route might not work and the systemic route might work. You have to remember that, and don't get discouraged if you don't get to treat the hypotony in the first, given the steroids via one route, try the other route. So this is a case of severe hypotonies secondary to cleft, cyclodialysis cleft. The idea was to treat the eye. This was an accelerated cataract and after trauma, and it's very difficult even to insert your eyes doing a corneal wound, and the idea was to treat the cataract and inject silicone oil. You can see it's not even easy to put your instruments to do a corneal wound. The idea also was to implant a 3-piece intraocular lens to mimic the effect of a Chioni ring, which helps corneal capsular tension rings, which helps to increase the resistance to aqueous outflow. Again, surgery is, for me, is the last resort in this case. You see how difficult it is. I always suture. I always suture the corneal wound when I do combined surgery. I avoid combined surgery, but when this is the option, I always suture the corneal wound. You can see bleeding even when doing nothing. It's very difficult. This patient was referred to London and had cleft suture, but again, it was a very, very difficult case. So some take-home points for ocular hypotony. You have to identify the clinical versus non-clinical hypotony. So don't trust only your readings, but try to see if your patient is really clinical hypotenuse. You have to identify the source and duration of hypotony, source if it's a ciliary body shutdown, or only a shock of the ciliary body, or a cleft, which has a different approach. And the duration of hypotony, if it's acute or chronic, it's very important. Use multimodal imaging. It can save you, and it can help you set realistic expectations for your patient. You have to be very careful with intraocular laser measurements. Ideally, you wait and till the eye gets back up, and then you measure the intraocular lens, so you can use the fellow eye measurements. And you use medical treatment first, and you keep surgical approach as the last resort, because you have to remember nothing can work miraculously in saving end-stage hypotenuse eye. Thank you.
Thank you, Sophia. And thank you, all of you, again for yet another wonderful webinar from IUSG. Now, a couple of questions. The controversies. Lucia, you illustrated beautifully the pathogenesis. Now, do you think if we deal the inflammation very aggressively early on, say biologics for our kids with JIA, is it going to reduce the incidence of cataract and then hypotony? Because honestly, I do not see BSKs and cataract now like we used to see in the children treated more than a decade ago. So I would like the experience of the panelist on this.
I agree with Joey. Nowadays, I don't see much uveitic cataract in the children because we treat them aggressively with biologics. And also the need for the topical drops is much less because they are on the biologics, and that will reduce the chances for them to progress to the stage when you have to operate. So in the recent years, my GIA patients were well within their teenage 20s when I was pushed to operate on their eyes. And in that case, the question whether to keep them aphakic or implant the lens is a little bit less difficult to answer, because you might want to actually rehabilitate their vision and put the intraocular lens with the primary surgery. But I agree, less steroids for any condition, less chances for development of the cataract in these patients.
And Sunfik, Sophia, Professor Gupta, Heliosa, your comments on the aggressive management in the beginning rather than resorting to biologics only when the conventional DMRDs fail. Because to be very honest with you, I haven't analyzed the data, but I don't remember seeing BSKs and hypotonies anymore, because that will bring to the next controversy of putting the IOL or not. So I'll go to Sunfik first.
Yeah, thanks for the question. I don't treat that many children, but for those that I treat, I tend to be very aggressive. And sometimes if it's a chronic disease, I don't even start with steroids because I think in children, they can do more harm. And very often, we'll start with methotrexate, and if that fails very soon, we would move on to biologics. The only concern, of course, is cost for the mother. That's what they would say, they can't afford it, but otherwise, I think that would be our recommendation. And the case I showed, pediatric uveitis, it was a patient who had come from another country who had been actually treated as TB when it was VKH for 6 months. And when he came, he had already a white cataract. And that's quite rare today. So most of the time, we're doing much earlier and earlier cataracts as we get better and better with our immunosuppressive therapy. Thanks.
So, Heloisa, I will come to you regarding a different question. You showed that absolutely no IOLs in JIA, and I agreed with you. I even answered one of the comments. Ashraf asked when can you put a secondary IOL? And I said no IOLs, because when we see the children whom we have implanted IOLs 10 years ago, 14 years ago, most of them end up with what you were showing: phimosis, anterior capsule, posterior capsule opacification. So what is your take on putting the IOL after Julio showed about reduce in hypotony? And second, about how much complicated cataract it's going to be. Like post-biologic, it's a very different spectrum compared to pre-biologics. Would that influence your choice of putting the IOL or not?
I have read many studies on putting the IOL, and recently I tried in one patient that had unilateral cataract with 5 years old, and I regretted because she, although the surgery was perfect, in the postoperative she had phimosis and she captured the IOL, and now for me it's worse to remove the lens and leave her aphakic, and she's 2100. So I have better results when I do not use the IOL, even with the best treatment available, with biologics and methotrexate. And sometimes in our reality here, we need to use steroids. And sometimes when the children comes to us, they already have cataract. And so when they are in the age less of 7 years old, it is an urgency because of the amblyopia. So we have many cases that in the diagnosis, the children already has cataract. So in my opinion, we have better results if we do not use IOL in JIA patients.
So Professor Gupta, I'll come to you. You used to do lensectomy, anterior vitrectomy, leave the children aphakic, and I was trained with you. You were very happy with them. And then came an era where we published that you put an IOL and inject the DEXA implant, and they do well. Now, looking back all these years, what will be your advice today?
Vishali, to first initially respond to your first question regarding aggressive therapy and less aggressive therapy. I think there are so many variables. What part of the world you come from? Are you from a developing world, or you're from because IUSD now represents, I think, global representation. So there will be ophthalmologists listening to your talks and webinars come from areas where there's not even an ophthalmologist, but to talk of a uveitis expert, or to talk of a pediatric rheumatologist. So if you have resources, if you have a pediatric rheumatologist, and if you have a uveitis expert who is experienced in the use of biological, nothing like it. I mean, it doesn't take any guessing that more aggressive treatment, the earlier the treatment, these patients will have less complications. And that is how you see, we read the literature from the Western world, where they are catching them very early because of their very extensive screening programs and guidelines, which people tend to adhere, at least in the developed world, but not so in the developing countries. And they can get away, like what Sunfek shows, putting an implant in these eyes because they are not chronically damaged. But what Helios has shown, and I agree with her, that putting an implant in eyes which are poorly controlled, extensive synecdoche, low pressure, hypotenuse eyes would be a very bad idea, putting an implant in some such eyes. And I just want to add to the hypotony bit. And as you rightly pointed out, I would prefer, if it were my eye, my child's eye, I would like to remove the crystalline lens along with the vitreous surgery. And if you look at the original paper from Diamond and the 78 paper, where the vitreous surgery was described in non-infectious uveitis, they said that, well, it leads to resolution of inflammation and cystoid macular edema if you combine lensectomy with vitrectomy. So that was the Diamond Kaplan series, where they shown the great response to surgery by removing all this stuff. The other important point, which has been somehow overlooked because focus was on cataract surgery, is preoperatively looking for ciliary body processes. Are these processes atrophic? Because chronic inflammation will lead to atrophy of ciliary processes. On UBM, if you pick that up, we know that this eye, no matter what you do, this eye is going to remain hypotenuse. And the advantage of doing a complete vitreous surgery is that you can fill these eyes with silicone oil, be 5,000 centistokes or whatever is available at your end. So there is a possibility of doing that. But if you find that it's only a tractional, it's a cyclitic membrane which is pulling on the ciliary processes, which is leading to deficiency in aqueous production, then removing the cyclitic membrane or dissecting and kind of segmenting that cyclitic membrane helps to restore the aqueous flow, and the hypotenuse can be restored. And I think you recall we have published our work in Retina more than 20 years ago on how to deal with eyes of uveitis with chronic hypotony by doing pars plana vitreous surgery and by preoperative evaluation, you know exactly what to do. I'm not so sure if putting, viscoelastic agents like Helon would give you a permanent solution. You need to use something more permanent, and even in small eyes, like these hypotenuse eyes, I think this was also overlooked, tend to become small. Hypotenuse, they become, like 16 millimeters, 17 millimeter, their size is reduced, they become microphthalmic. So even in those eyes, even if when they're presenting with light perception vision, you do lasectomy, vitrectomy, and if need be silicone oil, you can restore a very good ambulatory vision. And one of the child, I still distinctly remember, went to university, after clearing, and she came to us with bilateral light perception vision and 16 millimeter eyeball. So some of these spectacular results can be achieved if you have a great preoperative planning on how do you wish to proceed with your patient with hypotony and cataract. I hope I answered some of these questions.
Yes, sir. Sophia, you beautifully showed about ciliary body atrophy and how to distinguish it on UVA. Now, in the era of diflupred, and you said it very beautifully, that all the patients do not need to be managed surgically, because many of them, in real life, we are able to keep a pressure of 6, and they keep on doing well over a period of time. Now, what exactly is the situation which you said would be last resort? The surgery, like Sir said, traction on the ciliary body. And you also showed cyclodialysis cleft. Anything else you would go for surgical intervention just for hypotony?
As I said, the surgery for me is the last resort. You have to try and manage this patient medically first. Again, you have to distinguish if it's acute or chronic, because if it's acute, to my view, it's more easy to manage. You have to treat the inflammation, okay, to manage hypotony if it's an acute one, or if it's a trauma and it has a cyclodialysis cleft. If it's chronic, again, you have to treat the case, and you have not to be afraid of immunomodulatory and steroids, anything you have in your armamentarium. I had cases when single eye JIA patient, after vitrectomy, because she had vitreous hemorrhage, she had 0 pressure in her only good eye. So I injected Kenalog because we didn't have DEXA implant. I didn't have DEXA implant in hands. And it's difficult to inject a DEXA implant in hypotony. I injected Helon, it didn't work. And the only thing that worked was intravenous steroids. So you have to use everything you have in your armamentarium. I'm quite happy in some cases, selected cases with Trazil, but it's very difficult to find. And when I go to surgery, for me, I think it's the very last resort, and you have to remember that if you have an eye that is prephthalmic, this is what is the surgery indicated for. Inject silicone oil. The silicone oil might come up front, as it always does in phthalmic eye. I would do, as Professor Gupta said, to peel the membranes. This would be the ideal injection, but putting a silicone oil in a hypotenuse eye, you only buy up time. This is my view. Because silicone oil can cause more problems than, you only buy some time.
So before I end, Rima, there is a question which is coming up again and again. In a very well-controlled uveitic patient, would you give pre-op steroids? I think this has come the 4th time. Sunfik is typing the answer right away. So what is your take?
Let me see what Dr. Chi says first.
So
personally, I would prefer to give a shot of steroids pre-op, because we cannot be that, we can't take it for granted that nothing is going to happen if it's controlled.
Shot means intravenous?
No, pre-op maybe a day before.
No,
And
intravitreal or intravenous?
oral steroid.
Oral steroids.
Oral
Okay.
steroid, maybe start a day before and then continue seeing the post-operative course. If everything is okay, you can taper it fast and stop. If it is required more, then we can, do a slow tapering.
Sudfig, you give DEXA in the anterior chamber. So if you're doing that, do you still increase pre-op?
So I think it really depends on the type of uveitis and how well
Right.
you've controlled the condition. So in a well-controlled case, generally I want to see whether the patient has risk of macular edema. If the patient doesn't have any risk of macular edema, then generally I would just give intracameral DEXA. If the patient has got risk of posterior segment inflammation, I would give Ozurdex on the table at the same time. Today, it is rare for me to give oral steroids preoperatively. I might consider that if it's just a one-eyed patient, maybe with Behçet's disease or something really, severe. But generally, I've not really found the need to do, any kind of preoperative steroids. I would just give it on the table. And this has worked well for the type of cases that I see in my clinic. I think what is important is that we must not taper the steroids off too quickly, because this is what causes a rebound inflammation. And then the patient has a worse outcome at 6 months or 1 year. Yeah. Thanks.
Any of the panelists want to give any last word of advice?
I have a question.
Yes.
This is put up by Shahana also. Non-JIA cataract cases, what about IOL? Because some of them who have iris bombay and seclusia or occlusia, of course, we don't put IOL. But if it is a non-JIA, no iris bombay, no hypotony.
We should. I would. I would put IOL. I think everybody is saying yes. Sophia, your hand is raised. Is it? You want to say something?
Yes, about JIA, I would say that my absolute contraindication, I do operate on young children, but my absolute contraindication, it's a very young patient, a very hard to control disease, inability for a follow-up, and a failed intraocular lens in the contralateral eye. My contraindication.
Yeah, JIA is somehow
strict. No,
I wouldn't put an IOL now. I may have done.
Say one word. Just must keep in mind the age at which you are operating on these patients. A JIA patient whom you are operating at the age of 4 years or 5 years, he has at least 80 or 85 years to go compared to a 75-year-old man. When you are trying to put an implant where it might be well tolerated. But just imagine, and this is where, typically I'm not complaining, but cataract surgeons don't see their patients beyond 2 or 3 months. Whereas the uveitis patients who want to get cataract surgery need to be followed up lifelong, because these complications, which were amply shown, during the course of the webinar, they emerge much later. So please bear that in mind. Whenever you are taking a decision, keep that factor in mind. Who knows what kind of technology is going to come for secondary implants or corneal implants or, epi implants or epicorneal implants or contact lenses, which might make it absolutely safer, for these eyes to sustain. So we need to look at the sustainability of your surgical procedure for the 8 or 9 decades. And I'm being very, very serious about this issue.
Yes, when they develop retinal detachment or something, there is so much fibrosis, you can't do anything about the IOL. You can't even take it out. So it becomes a real problem.
Whatever case I have operated, Vishali, and I've done a few in my lifetime, and there have been in these post-implant kind of JIA kind of eyes, where there have been so-called fibrosis or phimosis and decentration and extrusion of the implant from the back. I have found that this adhesions or fibrosis extends beyond the posterior capsule, goes into the ciliary body, and is a part of continuum of cycled membranes. So you have to do a really tough dissection there in the anterior segment, to get rid of all those membranes, not behind the IOL, but also which progress into the ciliary body, and they pull on that 360 degree, they pull, and that's how these eyes are becoming, small hypotenuse size.
Well, with this, I would like to thank you all for your participation. And as far as our CME credit hours go, you will receive an email. Please fill in the feedback, which we always look at and improvise, and you will get the CME credit hours as per European accreditation. And we look forward to see all of you. Thank you, panelists. And our last webinar of the series is glaucoma surgery in uveitis, glaucoma in uveitis, which is on 7th of October. And Heliosa has a very special guest. Hi. So thank you all. Hi.
Thank you, everybody. Thank you, Vishali.
Thank you. Bye-bye.
Thank you.
Thank you,
Bye.
everyone.
Bye.
Bye.
Heliosa,
Thank you. Bye-bye.
Bye.
Bye-bye.
Bye.